height and weight. In a trauma patient who is in shock, the pulse rate and blood pressure are extremely important. In a woman with a breast mass, they are not. Personal habits are irrelevant in deciding whether somebody has a brain tumor, but would be virtually diagnostic in someone with a neck mass. By contrast, the questions in this audiobook and the accompanying PDF are primarily designed for content review and are abbreviated versions of the longer, ritualized format of the actual USMLE or shelf exam questions. They are not cluttered with vital signs and other facts that will not help. Rather, these questions contain only the key combination of facts that should be immediately recognized by an astute clinician. I want to recognize the contributions of Dr. Adil Faruqi, who brings with him his surgical experience in the West Coast to add to mine in the state of Texas. Carlos Pestana, MD, PhD, San Antonio, Texas. About the author. Carlos Pestana, MD, PhD, is currently an emeritus professor of surgery at the University of Texas Medical School at San Antonio. A native of the Canary Islands, Spain, Dr. Pestana graduated from medical school in Mexico City, ranking #1 in his class, and subsequently received a doctorate in surgery from the University of Minnesota in conjunction with a 5-year surgical residency at the Mayo Clinic. Throughout his career, he has received over 40 teaching awards and prizes at the local, state, and national levels, including, among the latter, the Alpha Omega Alpha Distinguished Professor Award from the Association of American Medical Colleges and the National Golden Apple from the American Medical Student Association. In the late 1980s and early 1990s, Dr. Pestana was a member of the Comprehensive Part 2 Committee of the National Board of Medical Examiners, which designed what is now the clinical component of the licensure examination, Step 2 of the USMLE, and he also served for 8 years as a member at large of the national boards. About this audiobook. This audiobook contains 13 chapters of surgery review, followed by 180 vignettes with practice questions. It also includes brief essays providing a surgical perspective on selected tools from the diagnostic and therapeutic armamentarium. You'll hear a tone like this prior to each essay. After the essay is over, you'll hear a tone like this before returning to the main text. You can find images illustrating various topics discussed in this audiobook in the accompanying PDF. The PDF also contains the 180 surgical vignettes and questions, along with the answer choices and answer key. Section 1. Surgery Review. Chapter 1. Trauma. Initial Survey. The ABCs. Airway. An airway is present if the patient is conscious and speaking in a normal tone of voice. The airway will soon be lost if there is an expanding hematoma or emphysema in the neck. An airway should be secured before the situation becomes critical. An airway is also needed if the patient is unconscious with a Glasgow Coma Scale of 8 or under, or his breathing is noisy or gurgly if severe inhalation injury, breathing smoke, has occurred, or if it is necessary to connect the patient to a respirator. If an indication for securing an airway exists in a patient with potential cervical spine injury, the airway has to be secured before dealing with the cervical spine injury. An airway is most commonly inserted by orotracheal intubation under direct vision with the use of a laryngoscope, assisted in the awake patient by rapid induction with monitoring of pulse oximetry, or, less commonly, with the help of topical anesthesia. In the presence of a cervical spine injury, orotracheal intubation can still be done if the head is secured and not moved. Another option in that setting is nasotracheal intubation over a fiber optic bronchoscope. The use of a fiber optic bronchoscope is mandatory when securing an airway if there is subcutaneous emphysema in the neck, which is a sign of major traumatic disruption of the tracheobronchial tree. If, for any reason, laryngospasm, severe maxillofacial injuries, an impacted foreign body that cannot be dislodged, etc., intubation cannot be done in the usual manner, and we are running out of time, a cricothyroidotomy may become necessary.